Okay, so the last section we're going to talk about today is anticoagulants, and Aaron's going to start us off.
So let's talk first about standard weight heparin or unfractionated heparin. This inhibits clotting factor activity on the intrinsic limb of the clotting cascade, right, by potentiating the effect of antithrombin 3. It does not cross the placenta, and actually low molecular weight heparin also doesn't cross the placenta, so both of these can be used in pregnant patients. Complications, well, bleeding, of course, decreased platelets from heparin-induced thrombocytopenia. This is reversed by protamine, and a good rule of thumb here is that 1 milligram reverses 100 units of heparin administered.
So low molecular weight heparin, so it's at least as efficacious as standard heparin, but the benefit here is it's once or twice daily dosing. The other thing is you don't have to monitor it because it's a very reliable dose and response curve. If you do want to monitor it, you can do anti-10A activity and you can assess that. And each low molecular weight heparin product is dosed differently, so it's just important to refer to dosing there.
What about warfarin? So we said that warfarin inhibits liver synthesis of the vitamin K-dependent clotting factors. That's 2, 7, 9, 10, and actually also protein C and S, right? So it's important to remember that initiation of warfarin without a bridge leads to a transient prothrombotic state. It's monitored by PTINR testing. Over anticoagulation can also prolong your PTT because both the PT and PTT measure the function of the final common pathway. Lots of drugs interact with warfarin. I don't have to tell you this. And of course, certain foods can decrease the effect. So for example, people who eat a lot of vitamin K containing vegetables can kind of negate the effect of their warfarin.
So what about reversal? So, how fast you're going to reverse these patients, this depends on the clinical situation, right? Are they bleeding? Are they not bleeding? If they're not bleeding and it's elevated, they may just be able to hold their dosing for a couple days. If they're actively bleeding, they will need more serious intervention. In all cases here, you're going to stop the drug. Okay, you may give vitamin K either PO or IV in the cases of significant bleeding. You can also treat patients with 4-factor PCCs, and FFP is also a possibility if you don't have PCCs available. It's also significantly cheaper than the PCCs.
So what about the DOACs? These used to be called the NOACs when they were novel oral anticoagulants, but now they're not novel anymore, so they're just direct oral anticoagulants. Broadly, they fall into two groups. That's the direct thrombin inhibitors and the factor 10A inhibitors. Both of these are orally dosed, both have predictable effects, lots fewer drug and food interactions than warfarin, shorter plasma half-life, and seem to have improved efficacy to safety ratio versus warfarin with pretty easy dosing for patients. Primary indications here, non-valvular AFib to prevent stroke or treatment of venous thromboembolic disease.
Okay, so let's talk about the direct thrombin inhibitors. So you have dabigatran. So this is excreted by the kidneys. This is a component in the final common pathway of the clotting cascade. You can see a rise in APTT, but you cannot use an INR to assess bleeding risk here. So there is a reversal agent direct for this. This is idarucizumab. It's pretty expensive, but it would be the treatment of choice in patients who have significant bleeding and are on this medication.
And I think, prescribing for dabigatran and direct thrombin inhibitors, I think, has mostly gone down, and prescriptions now are being written more and more for factor 10A inhibitors. Factor 10A is a component of the final common pathway of the clotting cascade. You really can't use APTT tests to determine in any quantitative way whether a factor 10A inhibitor is present. You can't use a PT or an INR. If your PT is prolonged, that probably indicates excess bleeding risk, but again, it's not quantitative, it's not linear, and it depends on the drug. So for example, apixaban, much less good at prolonging PT even in a non-meaningful way. Drugs include here rivaroxaban, apixaban, or edoxaban. And notice that all of these depend in part on renal excretion, so acute renal failure in a patient who continues to dutifully take their drug can lead to problems with excessive anticoagulation from impaired drug clearance.
So this chart, this is a great comparison of the DOACs, and it'll just give you an indication of where they work in the cascade, in the clotting cascade. It'll tell you about the half-life, and again, modes of excretion here, and the max concentration and dosing.
So what do you do with bleeding on direct oral anticoagulants? So, the maximum effect on coag tests occurs about 3 hours after ingestion. So it's important for all kinds of reasons to know when the drug was taken, how much was taken, when was the last dose. Time is the most important antidote in the setting of non-life-threatening bleeding because the relatively short half-life of these drugs, as long as clearance is normal and isn't impaired by organ dysfunction, you may be able to wait it out in non-life-threatening or non-serious hemorrhage. Normalization of hemostasis usually within 12 to 24 hours with the 10A inhibitors and the direct thrombin inhibitors, but again, that assumes normal renal function. You actually can do dialysis for direct thrombin inhibitors like dabigatran, and in the early experience with the drug and post-marketing, that's what was done for dabigatran overdose or excessive drug levels with severe bleeding. So first things first, initiate local hemostatic measures. If the patient needs surgical source control, do that. Replace fluid volume or PRBCs. Know that FFP does not reverse DOACs. So, in our institution, the first line is prothrombin complex concentrates. There is some less than perfect evidence of their efficacy. They are expensive, but not as expensive as an incompletely tested antidote called Indexinet alpha that Jess is going to tell you about in the next slide. Factor 7A, which is an activated clotting factor and therefore carries more of a thrombosis risk, can also be given. And then you can consider giving tranexamic acid, which is an inhibitor of fibrinolysis. It's really cheap. So is desmopressin, which again transports factor VIII and stimulates the release of von Willebrand factor. Idarosizumab is a dabigatran-specific monoclonal antibody neutralizer. Expensive, but it is drug-specific and not in and of itself prothrombotic. There is an FDA-approved recombinant modified factor 10A, that is a non-prothrombotic factor 10A that competes with natural 10A and binds up the DOACs, and that's called Indexinet alpha. It has been tested to show some early efficacy in normalizing bleeding tests, but it requires an initial dose plus a continuous infusion, and it's not totally clear what happens after that infusion is over. And always know that even if you use a non-prothrombotic antidote to reverse a patient's anticoagulation, there was probably a reason they're anticoagulated, and so there is some risk of clotting, and you need to undertake a risk-benefit analysis, and this sometimes is an appropriate place for shared decision-making with the patient.
And with that, we are going to conclude the trauma and bleeding section. Thank you guys so much. We wish you the best of luck, and we hope that this information will help, again, bring it to the forefront so you can easily access it during the test, and all these slides will be available for you to use and to reference during your exam.
Yeah, good luck on the module, and don't forget about the searchable index. You can pick any topic you want and get right to the slide that you need to reference.